Dear colleagues, my subject is about approached intermittent exotropia. In this patient, we see good alignment for near, but while we are examining for the far, there will be outward deviation of both eyes. In this patient, there is exodeviation for near and also exodeviation for far. For far, it is more than near. In third patient, also there is exodeviation for near and it increased 10 prism diopter for far. Dear colleagues, as we know that intermittent exotropia is the most common type of strabismus. It is characterized by occasional outward deviation of one or alternate eyes. The frequency, duration of elevation, and control vary from individual to individual. Typically begins before the age of 5 years old, usually preceded by a stage of exotropia. Intermittent exotropia comprise about 75 to 90% of the cases of exotropia, and it affects about 1% of general population. The deviation become manifested during illness, fatigue, or daydreaming. Often exposure to bright light or photography may elicit closure of the non-dominant eye. At the other part of the time, the eyes are normal. The tropia is usually larger at distance than near. Over the time, the disease can remain stable, resolve, or progress. Unfortunately, the disease is more in female. What is the etiology of our disease? First of all, innervational and mechanical. Second, defective fusion. Third, high ACA ratio. Fourth, refractive errors. Fifth, genetic. Others, such like low birth weight or craniofacial malformation or mother smoking during pregnancy. In adult, it is changed. There may be diseases such as thyrotoxicosis, stroke, or loss of vision in one eye. How we classify disease? The disease is classified into 4 groups. This system is based upon the concept of fusional convergence and divergence and relies on the measurement of the distance and near deviation. First, we have basic. The distant deviation is within 10 prism diopter of the near deviation. Second, divergent exists. Distance deviation is 10 prism diopter greater than the near deviation. Third, convergence insufficiency. The near deviation is 10 prism diopter greater than the distance deviation. And lastly, we have simulated or pseudo-divergent exists where the distance deviation at first is greater than the near, but after closure of 30 to 16 minutes of monocular occlusion, the near deviation increased to within 10 prism diopter of the distance deviation. How we diagnose? What's our diagnosis? Of course, all assessment of sequence must apply to our patient. Moreover, there is specific points we must take care. One of them is assessing the control of intermittent exotropia. Why we do this? We do this to obtain a baseline evaluation to monitor the deterioration and progression of the disease. At the home, what shall we do at the home? We shall ask the parent we told them to keep a chart noting the control of deviation in terms of percentage of working hours to the duration of manifest duration. Of course, this needs a very cooperative family and intelligent. They must be intelligent to do this step. In the office, what shall we do? First, we must know what is the control of the disease. When we say it is good control, when the patient breaks only after covering test and resumes fusion rapidly without any need to blinking or refixation. While we say it is fair control when patient can blink or refixation to control the deviation after disruption with cover test. We have poor control when patients break spontaneously without any form of fusional disruption or who does not spontaneously alignment despite blinking or refixation. There is an important point. We must know the stereopsis of the patient. We must examine the distance stereo acuity. It will provide us an objective assessment of both control of deviation and deterioration of fusion. While for near, of course, we have many tests. It is available. It can be used as a marker for deterioration of the disease, and it has no relation to the control of deviation. While doing alternate cover test, due to the variable angle of deviation, measurement in a patient with intermittent exotropia can be difficult. So what must we do? A prolonged alternate cover test should be used to suspend tonic fusional convergence. After that, we must do patch test. Patching one eye for 30 minutes will suspend the tonic fusional convergence, and this reveals the actual amount of deviation. After that, we do lens gradient method. For whom we do this? This test should be used in patients who had deviation of 10 prism diopter or more for distance more than near after patching test. +3 near at test. This can be distinguished the pseudo-divergent axis from the true divergent axis. How we will manage our patient? Of course, we shall start with the non-surgical, then there is certain indication when we must do surgical treatment. For non-surgical treatment, first of all, we started with observation. Of course, not every patient. It is done for the patient who are good control, asymptomatic, and has good binocular fusion. Correction of refractive error is a strong point, and when there is high AC ratio, we must do over minus lenses. Patch time occlusion has a role in our disease. It is found that it is useful in very young children. Part-time occlusion of the non-deviating eye may convert the intermittent exotropia to phoria by treating the suspension and amblyopia. Although the benefit may be temporary, occlusion can be used to postpone the surgery in responsive patient. Sometimes we need alternate inclusion may be used in patients with equal fixation preferences. Orthoptics. We know this famous test convergence exercise such as pencil push or computer orthoptics. Some speak about prism, but it is rarely used for long-term management. All of us, we will sometimes ask ourselves, what is the timing of surgery? There is no defined optimum age or timing for surgery. Most studies have failed to show that age at time of surgery make any differences in the outcome. What are the indications of surgery? Of course, there must be signs of progression. What is the signs of progression? First of all, increase the frequency of the manifest phase. Second, we have increase in magnitude of deviation. Third, we have difficulty regaining fusion after dissociation during cover test. Lastly, if there is decrease of stereo acuity. What are the types of surgery used in our patient? Often we have many types of surgery, many choices we use in our patient, but this depends upon the angle of deviation and whether the deviation is more for far or near, if there is any amblyopia, and if there is any oblique muscle overaction. What is the prognosis of our disease? Due to the lack of a standard deviation for a successful outcome, of course, the patient need 100%, and variability in classification systems. We have multiple treatment approach, deficiency of long-term data, so it is difficult to determine the true outcome of the currently available treatment for intermittent exotropia. At last, the successful rate in all types of our disease has been about 60 to 70%. Thank you very much.